everyone. Today we are going to discuss about restrictive cardiomyopathy. We all know that cardiomyopathies are of three types. One is dilated cardiomyopathy, another is hypertrophic cardiomyopathy, and third is the restrictive cardiomyopathy. If we look at the definition of the restrictive cardiomyopathy, it is the broad classification of heart diseases which is characterized by predominance of severe diastolic dysfunction with normal or mildly increased ventricular wall thickness and either normal or mildly reduced ejection fraction. And if we look at the prevalence, so it is found in 1 in 500 people, and it is the rarest type of cardiomyopathy. About 5% of all cardiomyopathies are restrictive cardiomyopathy. So if we differentiate it into primary restrictive cardiomyopathy and secondary restrictive cardiomyopathy, then we can put idiopathic restrictive cardiomyopathy and endomyocardial fibrosis under the group of primary restrictive cardiomyopathy, and in secondary restrictive cardiomyopathy, infiltrative cardiomyopathies like amyloidosis, sarcoidosis, primary and secondary form of hemochromatosis, other storage disorders like glycogen storage disorders, Fabry's disease, metastatic cancers, and radiation induced form of the disease, they will all come under the group of the secondary restrictive cardiomyopathies. So restrictive cardiomyopathy can be inflammatory, can be non-infiltrative, can be infiltrative, can be associated with storage disorders or idiopathic. So under the group of inflammatory restrictive cardiomyopathies, there are diseases which come under this group. These are endomyocardial fibrosis, Loeffler's cardiomyopathy, and post-radiation therapy. So they will come under the group of the inflammatory restrictive cardiomyopathies. When under the group of non-infiltrative cardiomyopathies will be hypertrophic cardiomyopathies, diabetes, familial, and scleroderma. In infiltrative group, there are two diseases. One is amyloidosis and sarcoidosis. Under the group of the storage disorders, there will be hemochromatosis, glycogen storage disease, and Fabry's disease, and another group last is the idiopathic restrictive cardiomyopathy, where we can't find any cause. So there are different etiologies are found in different age group of the patient. So if we divide them, like in which age group which etiology is more common. So if we take the group of non-infiltrative restrictive cardiomyopathies, so if the patient's age is less than 30 years, then in that group, idiopathic RCM and scleroderma are more common. If the patient's age group is between 30 to 65 years, then we should think about either idiopathic RCM or scleroderma or pseudoxanthomyelesticum. And in older age group of patient, if the patient's age is more than 65 years, then idiopathic RCMP is more common. In infiltrative disorders, if we all know that like storage disorders are more common in children and in young in teenage group of the patients. So if in infiltrative group, if the patient's age is less than 30 years, then sarcoidosis, Gaucher's disease, Hurler's disease, these diseases are more common. If in age group of 30 to 65 years, most common diseases are amyloidosis and sarcoidosis, and if the patient's age is more than 65 years, then we should think about amyloidosis first. Now coming to the storage diseases like Fabry's disease, glycogen storage, and hemochromatosis, they are more common in less than 30 years of age, and other like iron overload, we can say that secondary hemochromatosis are more common in age more than 60 years. 60 years as well as in age more than 30 years. And when we think about and when we talk about endomyocardial diseases as the etiology of restrictive cardiomyopathy, then endomyocardial fibrosis and hypereosinophilic syndrome are more common in age group of less than 30 years and also in 30 to 65 years age group. Similarly, HES is common, and also the carcinoid disease is also common. Drugs like chloroquine that can also cause restrictive cardiomyopathy, and which are commonly seen in adults. And other older adults, like in age group of more than 65 years, if we talk about the endomyocardial diseases group of the RCM, then hypereosinophilic syndrome and metastatic tumor and radiation induced this restrictive cardiomyopathies. These are the common etiologies of restrictive cardiomyopathies found in older adults. Now the pathophysiology of restrictive cardiomyopathy. So basically restrictive cardiomyopathy means it is stiff ventricle. So due to the stiff ventricles there will be backward failure. So if we talk about right side of the heart, due to the stiff right ventricle there will be increased RA pressure, and so there will be systemic venous congestion, and there will be edema, there will be hepatomegaly, there will be ascites, and due to the stiffness of the left sided ventricle there will be increased LA pressure, which will lead to the pulmonary congestion and dyspnea and this rails on clinical examination. There will also be forward failure due to limited preload and limited stroke volume. So with exercise there will be reduced cardiac output, and which will ultimately lead to fatigue and exercise intolerance. Clinical characteristics of restrictive cardiomyopathies in general are like heart failure is the most common initial presentation. So patient will come with dyspnea on exertion, and exercise intolerance is due to forward failure. And we already discussed that how exercise why exercise intolerance will be there in patients with RCMP due to a reduction in the stroke volume. There will be reduced preload as well as reduced stroke volume. It will lead to the exercise intolerance, and that's why there will be fatigue, and also lower extremity edema is due to the right sided heart failure, and chest pain is very infrequent. On physical examination, there will be typical JVP findings of prominent X waves and Y descent without any respiratory variation, and apical impulse will be mildly displaced, but usually it is palpable and usually it is normally found, and S1, S2 are normal, and typically there will be loud S4. Due to right-sided heart failure, there will be ascites, hepatomegaly, marked pedal edema, and even mitral clinical signs and murmurs of mitral and tricuspid regurgitation may be there because they are commonly associated with this. Chest X-rays are usually normal ventricular silhouette with enlarged atria, and a varying degree of the pulmonary congestion may be there. And ECG, there may be sinus rhythm with large P waves, which indicates atrial enlargement, and also sometimes there will be atrial fibrillation will be found, and there are typical characteristic features on ECG like pseudo-infarct pattern, which are very commonly seen in cases of amyloidosis, and there's AV blocks, bundle branch blocks are more common in cases of sarcoidosis. So we can find those changes on ECG. If we talk about the diagnostic evaluation, after doing the physical examination, then comes the echocardiographic examination. So usually the ejection fraction in LV and RV are normal, and normal ventricular chamber volumes with biatrial enlargement will be seen, and there will be restrictive diastolic filling parameters. So abnormal diastolic compliance will be there, and that we can find on Doppler echocardiographic examination. So there will be increase in early diastolic filling velocity, E waves, which reflects there is elevated left atrial pressures, and there will be decreased atrial filling due to the elevated ventricular diastolic pressure. So the E by A ratio will be more than 1.5. and decreased mitral deceleration time to less than 120 milliseconds, and also decreased isovolumetric relaxation time. So in this image we can see that there is a increase E and E by A ratio on the left side of the image, where the Doppler image of the mitral inflow is given. Even the lateral mitral annulus, we can see that E dash is reduced, which is typical of the diastolic dysfunction. So E dash is reduced so that the E by E dash ratio will be more than 15. And in the right sided lower image we can see that there are some granular pattern of the ventricular walls. There is a biventricular wall thickness is increased, and also there is biatrial enlargement. So most common differential is constrictive pericarditis. So we want to differentiate it from the constrictive pericarditis. Which are the parameters, means Doppler parameters and echocardiographic parameters, which help in differentiating restrictive cardiomyopathy from the constrictive pericarditis are like septal bounce is typical of constrictive pericarditis. There's respiratory variations in mitral and tricuspid valve inflow. They are also typical of constrictive pericarditis. These variations are not seen in restrictive cardiomyopathies. And the deceleration time is short, and it is also reduced in RCMP. Then there will be the typical as TR duration will be increased in constrictive pericarditis. And if we take RVSP, it is not mentioned in this slide, but RVSP is typically increased in cases, in the most of the cases with restrictive cardiomyopathy, while it will be normal in constrictive pericarditis. And E by E dash ratio, it is more than 15 in restrictive cardiomyopathies, while it will be less than 8 to 10 in cases of constrictive pericarditis. This is how we differentiate on the basis of echocardiography. Next comes cardiac MRI for diagnostic evaluation in cases of restrictive cardiomyopathies. So there are T2 weighted images and T1 mapping and gadolinium enhancement that we are going to discuss. So fast spin echo T2 weighted sequence, they indicate the myocardial edema. So we can find if the T2 mapping there is increased signals, then those indicate that there is underlying myocardial inflammation, there is underlying myocardial edema, and it will appear as hyperintense area. Similarly, if on T2 weighted sequences, if we find that there are decreased signal in intensities in contrast to hyperintense areas, so decreased signals will be found in patients with iron overload myocardial disorders, like in patients with hemochromatosis. And cases of like delayed myocardial enhancement, which is also indicative of myocardial inflammation and fibrosis, is seen in approximately 1/3 of all the cases of RCMP. And T1 mapping is also useful in quantifying the diffuse myocardial fibrosis. So delayed enhanced inversion recovery imaging, it results in nulling of the normal myocardium, and other side imaging which are characteristically, they can help in identifying certain infiltrative disorders like amyloidosis. And delayed gadolinium enhancement often provides incremental prognostic information beyond the serum biomarkers, especially in cases with cardiac amyloidosis and typically in AL type of cardiac amyloidosis. Even T1 sequencing, it proves to be more sensitive than the gadolinium for detecting early amyloid deposits. So this is how cardiac MRI helps us in diagnosing various etiologies of restrictive cardiomyopathies. So even cardiac catheterization is helpful in diagnosing restrictive cardiomyopathies, and typically it helps in differentiating restrictive cardiomyopathy from constrictive pericarditis. So typical findings, cardiac cath findings of restrictive cardiomyopathies are Actually, restrictive cardiomyopathies, they have abnormality in diastolic function. So there will be normal and diastolic volume, but the diastolic pressure will be high, and there will be deep and plateau type of diastolic deep, and equalization of the diastolic filling pressures in all chambers. There will be Y descent will be blunted relative to the X, and there will be blunted respiratory variation in transvalvular flows. Even we discussed it in echocardiography also, that there will be blunted respiratory variation in transvalvular flows. Kussmaul sign may be present. Pulsus paradoxus may be found in some cases, and there will be ventricular concordance. So what do we mean by ventricular concordance? So this image shows that what is ventricular concordance and what is ventricular discordance. So in cases of restrictive cardiomyopathy, we'll find ventricular concordance. So during the during inspiration, there will be fall in LV systolic pressures, as well as there will be fall in the RV systolic pressure altogether. And in expiration, we can find that there will be increase in the LV systolic pressure and increase in the LV diastolic pressure. So there is concordance in the pressure. So inspiration, they will fall, and in expiration, they will rise. While in case of the constriction, what happens is during inspiration, there will be increase in the RV systolic pressure, but at the same time there will be reduction in the LV systolic pressure. So there is concordance between the pressure. There will be discordance between the pressures of LV and RV due to ventricular interdependence. So this ventricular interdependence will not be there in RCMP, and so we will find concordance pattern in LV and RV systolic pressures, while due to ventricular interdependence, there will be discordant pattern of LV and RV systolic pressures in constrictive pericarditis. Endomyocardial biopsy is class 2A recommendation for diagnosing etiologies in restrictive cardiomyopathy, and one series from the Johns Hopkins, they say that diagnostic yield of this endomyocardial biopsy is only 29%, but it can diagnose some systemic diseases like amyloidosis and hemochromatosis. Even it helps in diagnosing sarcoidosis and Fabry's disease. So we will now discuss about commonly found restrictive cardiomyopathies. Like one is cardiac amyloidosis. It is the prototype of the infiltrative form of restrictive cardiomyopathies. Previously it was thought to be rare, but it is recognized that all the form of the cardiac amyloidosis are underdiagnosed, and it is the disorder of misfolded proteins which leads to the deposition of the insoluble amyloid fibrils in the heart and other tissues. So there are various types of amyloidosis which commonly affect the heart, and these types are very important because the treatment depends on the type of the amyloid. So incorrect typing will lead to the life-threatening mistakes in therapy. So it is very important to decide that which type of the amyloidosis is affecting the heart. There are various type of amyloidosis which affect heart. One is AL type of amyloidosis, where it is light chain type of amyloidosis, and the precursor protein is found in this bone marrow, and clinical features are like heart failure, weight loss, nephrotic syndrome, peripheral neuropathy, autonomic neuropathy, and PYP scan, it is pyrophosphate, technetium pyrophosphate scan is negative, or there will be mild uptake, and the treatment is also different, that we will discuss later on. If there is ATTR, transthyretin type of amyloidosis, either with mutation or without mutation is wild type of ATTR. In mutated type of ATTR, most common clinical features are heart failure, peripheral and autonomic neuropathy, and PYP scan is typically positive in transthyretin type of amyloidosis. So it will be positive in mutated type of transthyretin amyloidosis, as well as in case of wild type of transthyretin amyloidosis. Similarly, in wild type of transthyretin amyloidosis, most common clinical features are heart failure, atrial fibrillation, conduction diseases, and most of the patients are male, and even it is found in age group of mostly more than 65 years of the age. Now, AL type of the amyloidosis, it has clinically significant cardiac involvement in more than 75%, up to the 75% of the cases will have cardiac involvement, and the prognosis is bad in AL type of amyloidosis, because due to rapidly progressive heart failure, usually survival time is less than or equal to 9 months. In case of familial amyloidosis, ATTR mutated type, it is autosomal dominant. It involves both heart and peripheral nervous system. Usually young patients are, if young patients have this type of amyloidosis, they will have predominant peripheral nervous system involvement, and in the middle-aged patient there will be predominant cardiomyopathy. In senile systemic amyloidosis, ATTR wild type of amyloidosis, where we will not be able to find mutations, but it almost always affect heart. It is mostly seen in patients whose age is more than 70 years. Male to female ratio is almost 20:1, and there is also isolated atrial amyloidosis is there, and that involves typically the atria of the diseased heart. Disease specific echo findings in amyloidosis are, there will be increased right and left ventricular wall thickness, typical scintillating echo bright appearance of the myocardium, which is also called as the fine granular appearance of the myocardium with preserved ejection fraction, diffused AV valve thickness with biatrial enlargement, and on Doppler imaging we can find that there is impaired longitudinal LV systolic function with normal ejection fraction, and there are typical finding on speckle tracking, which is also called as bull's eye appearance. On speckle tracking, there is regional longitudinal dysfunction, which is more longitudinal dysfunction in base as compared to the apices. So there will be typical apical sparring of this longitudinal dysfunction, and it leads to the bullseye appearance. This image, these are the red flag signs on echocardiography. So there are some red flag signs on echocardiography which tells us about if those signs are present, we should suspect about cardiac amyloidosis. If there is typical granular appearance of the myocardial wall, like scintillating bright echogenic appearance of myocardial wall, as we can see on these echocardiographic images, if there is presence of pericardial effusion, if there is biatrial enlargement associated with AV valve thickening, then we should think about cardiac amyloidosis. So this is speckle tracking, and which shows that there is a gradient of longitudinal strain from apex to the base with well preserved apical strain pattern and severely impaired basal strain. So this pattern leads to the bull's eye pattern, which is typical of cardiac amyloidosis. And on this image, that cardiac MRI image is showing global subendocardial lead gadolinium enhancement, and the D image, it is showing pyrophosphate scan, where we can see that severely increased myocardial uptake, like grade 3 or even more than greater than bone, which is consistent with the transthyretin cardiac amyloidosis. So So disease-specific cardiac MR features of cardiac amyloidosis are diffuse circumferential subendocardial lead gadolinium enhancement. There will be restrictive morphology with a reduction in systolic thickening in this LGE areas, and there will be no myocardial edema and thickened atrial valves with atrial lead gadolinium enhancement, and there will be loss of atrial contraction. So this is the summary of what we learnt about cardiac amyloidosis. So if there is a primary type of amyloidosis, like if it is AL type of cardiac amyloidosis, the precursor protein is abnormal light chain. Usual age of onset is 50s, and the main organs are involved are like cardiac involvement is found in up to 75% of the cases, and all organs can be involved except central nervous system. And then if it is ATTR transthyretin type of amyloidosis, it can be either mutant or wild type of transthyretin amyloidosis. Mutant are seen in 20 to 70 years of age, and where common organs involved are heart and peripheral and autonomic nervous system. Even expected survival in cases with familial ATTR, it is 8 to 10 years for neuropathy, and if for primary amyloidosis, if it is involving heart, then expected survival is less than or equal to 9 months. And specific treatment would be chemotherapy or bone marrow transplant for AL type of cardiac amyloidosis, while in a familial type of cardiac amyloidosis, either liver transplant, or nowadays we can even give tafamidis in those group. Even in wild type of senile systemic amyloidosis, wild type of transthyretin, it is usual age of presentation is more than 70 years. A main organ involved is heart, and average expected survival is 5 to 7 years. And here also we can give tafamidis to suppress the production and to stabilize TTR. And isolated atrial amyloidosis is the precursor protein is ANP, and it involves particularly cardiac atria, and there is no effect on survival. While in the secondary deposits, secondary to AA type of amyloidosis, secondary to some inflammatory disorder, some inflammatory condition, it involves liver, kidney, heart. Heart is rarely involved, and the expected average survival is more than 10 years, and the treatment is to treat the underlying inflammatory condition. In sarcoidosis, now we are going to the next disease, that is sarcoidosis. Mainly the most common phenotype of sarcoidosis is dilated cardiomyopathy, and restrictive cardiomyopathy is still frequently described. It is more commonly found in females as compared to males, and most of the patients have evidence of known cardiac diseases. Isolated cardiac involvement is rare, and if the patient presents with like heart block or arrhythmia or unexplained reduced ejection fraction, or then we should suspect cardiac sarcoidosis in those cases. There are certain criteria for clinical diagnosis of cardiac sarcoidosis, which are given by the Heart Rhythm Society. So if all three of the following conditions are met, then it is considered that patient is having cardiac sarcoidosis. One of the first condition is that there is histological evidence of extra cardiac sarcoidosis. Second is that one or more of the following should be present, like the immunosuppressive suppressant responsive cardiomyopathy or heart block, unexplained reduced ejection fraction less than 40%, unexplained sustained ventricular tachycardia, or type 2 Mobitz block or the third degree heart block. There is like patchy uptake on FDG PET in a pattern which is consistent with cardiac sarcoidosis, lead gadolinium enhancement on cardiac MRI, and the pattern which is consistent with cardiac sarcoidosis. And third is like that other causes for the cardiac manifestation should be ruled out, they are excluded, then only we can diagnose that this is cardiac sarcoidosis. So if these three criteria are met, then the patient, we can say that patient is having cardiac sarcoidosis. These are the spectrum of the echocardiographic changes we may find in cases of cardiac sarcoidosis. In the first image it is a normal echocardiogram, then even focal aneurysms are very common in patients with cardiac sarcoidosis. You can see that there is focal ventricular aneurysm, and then last stage is dilated cardiomyopathy. So most common phenotype is dilated cardiomyopathy. On cardiac MRI, we can find multifocal intense LGE pattern, usually in septum and inferolateral wall of the LV, right atrium and RV free wall. There may be presence of regional wall motion abnormality with hypocontractile LV or RV, patchy bright regions which these are suggestive of myocardial edema, and there will be normal myocardial perfusion. So cardiac MRI findings which like consistent which are demonstrating that there is a abnormal late gadolinium enhancement which is consistent with the scarring, and the below is the image which shows there is a fused FDG pad which is suggestive of inflammation around the scar areas in sarcoidosis. So these are the typical of cardiac amyloidosis. So how to manage the patients with cardiac amyloidosis? So there can be rhythm abnormalities or there can be abnormalities in the myocardium. So if we find that there is myocardial involvement and it is proven on FDG PET or proven on cardiac MRI, then we should give patient some anti-inflammatory therapy in the form of like glucocorticoids or methotrexate, and if the patient is a candidate for CRT or ICD, then we should give it. Then if the patient has arrhythmia and if the patient has heart block or ventricular arrhythmia, then either ICD should be given to the patient or associated with anti-inflammatory therapy should be given to the patient. And for the patients with atrial fibrillation, either ablation can be given or steroid should be given. So prognosis of cardiac sarcoidosis when the patient presents with high grade AV block. So there is one study which is like a study included 325 patients of cardiac sarcoidosis who presented with high grade AV block, and they found that they divided those patients into three groups. One group is patients with ejection fraction less than 35 years and or ventricular tachycardia. There were only 20 patients in that group. Then patients with ejection fraction of 35 to 50% and there was absence of ventricular tachycardia, and ejection fraction of more than 50% and absence of ventricular tachycardia. And what they found was in the group 1, the 5-year cumulative incidence of sudden cardiac death was 30%, which is quite high. And in other groups also, there were 5-year cumulative incidence of sudden cardiac death was 14% and 9% respectively. So that if the patient presents with high grade AV block, then we should implant ICDs in place of pacemaker. So that implantation of ICD should be instead of pacemaker should be considered if the patient comes with cardiac sarcoidosis and high grade AV block. Then other storage disorders like Fabry's disease is a lysosomal storage disorder which is X-linked recessive disease, and it is deficiency of alpha galactosidase A enzyme. Usually it manifests with acroparesthesias, angiokeratomas, history of TIAs or stroke due to small vessel disease, and cardiac involvement is usually found in 3rd and 4th decade. They manifest it as They manifest as LV hypertrophy and they worsen with age. There are typical echocardiographic findings are like concentric LVH will be there will be mitral wall thickening with significant MR. On cardiac MRI, typical finding of Fabry's disease will be concentric LVH. There will maybe RWMA with wall thinning and absence of myocardial edema, normal myocardial perfusion, and mid-wall left gadolinium enhancement in inferolateral walls. Next is the hemochromatosis. Hemochromatosis, like it may be primary hemochromatosis, it may be secondary hemochromatosis, and multiple organs are involved in hemochromatosis. And cardiac involvement, it usually begins with restrictive non-dilated heart, and which progress to the systolic dysfunction, and eventually patient develops burnt out disease and dilated cardiomyopathy. And it is it is associated with conduction abnormalities and arrhythmias. Typical cardiac MRI findings in patients with hemochromatosis are hypocontractile LV with dark myocardium. There will be absence of myocardial edema, no normal myocardial perfusion, normal LGE mapping, but there will be decreased T2 weighted signal intensities which are seen in iron overload myocardial disorder. So decreased T2 weighted signal intensities, they are typical of hemochromatosis. Next disease is endomyocardial fibrosis. We can say that it is the most common form of RCMP worldwide in the world because it is very common in Africa and South Asia. It is more commonly found in males as compared to females. It has bimodal presentation. It is typically characterized by the fibrosis of the RV and LV apex, and it leads to the blunting, and there will be also fibrosis of the subvalvular apparatus. There is no causes usually found in those cases, and pathology usually resemble eosinophilic cardiomyopathy. These are the echo images of the patients of endomyocardial fibrosis. In the left sided image, we can see that there is fibrosis which is obliterating the RV ventricular apex, and also there are some thrombi. And on the other image, image B, is showing severe mitral regurgitation due to the deformed valve, due to the fibrosis of the subvalvular apparatus. Cardiac MRI findings which are seen in endomyocardial fibrosis, they are dilated hypocontractile LV and RV, absence of myocardial edema, normal myocardial perfusion, diffuse subendocardial lead gadolinium enhancement of LV or RV with or without thrombus, and there will be obliteration of the LV or RV apex. Next disease is Loeffler's or eosinophilic endocarditis. It occurs within the spectrum of hypereosinophilic syndrome, and hypereosinophilia is defined as absolute eosinophilic count if it remains more than 1500 cells per ml for at least 1 month. So there is chronically elevated absolute eosinophilic count. And cardiac involvement in Loeffler's endocarditis, it is categorized into 3 phases. One is acute, another is intermediate stage, and last is the fibrotic stage. In acute phase, we may not find any signs and symptoms in patient, but there will be myocardial inflammation and necrosis. Echo will be normal, only cardiac MRI with contrast can detect along with the cardiac biomarkers. In intermediate stage, there is there may be formation of thrombus at the endocardium at the apex, and we may find mitral and tricuspid regurgitation, and patient may develop the symptoms of heart failure. Due to this thrombus formation, there's thromboembolism to brain and other organ is also common in this intermediate stage. Then comes the last stage of fibrotic stage, which is leads to the diffuse scarring, and due to that there will be endomyocardial fibrosis and the features of RCM. The scarring also involves mitral or tricuspid subvalvular and leaflet. So there will be involvement of the leaflet as well as subvalvular apparatus. So it leads to the regurgitation of mitral and tricuspid valve. Next is carcinoid heart disease. Sometimes these patients present with features of restrictive cardiomyopathies. So it is carcinoid heart disease is a part of carcinoid syndrome. It is part of this metastatic neuroendocrine tumor. Hepatic mets, they release elevated vasoactive substances like 5-HT, and that's why it involves right side of the heart predominantly. And there will be myofibroblast proliferation and collagen deposition. So there will be thickening of the right sided heart wall, there will be thickening of the tricuspid wall, and there will be retraction of the tricuspid wall, which ultimately will lead to the tricuspid wall regurgitation. Even it leads to the pulmonary root constriction, then tricuspid annular and subvalvular involvement will be there, and high levels of this 5-HT in right side of the heart, it causes the progressive fibrotic endocardial plaque. So this is an image. This is histopathological findings, which are we can see that there is fibrotic subvalvular apparatus, and on echo also we can see there is dilatation of the right side of the heart, and tricuspid valve is involved here. General management principle in patients with restrictive cardiomyopathy are like we should relieve congestive symptoms with diuretics, and at the same time we should try to avoid hypotension. These patients are prone to develop hypotension. So diuretics should be given. Patient should be advised for salt restriction up to 2 to 4 grams per day, and even fluid restriction up to 2 liters per day should be given to the patient. If patient has presence of atrial fibrillation, then in these cases of restrictive cardiomyopathy, we would like to do rhythm control over rate control, because it improves the diastolic filling, and it will improve in it will lead to the increased forward output as well. So we would like to do rhythm control in these cases as compared to rate control, and even after giving this treatment, no pharmacological treatment prolongs survival. Then disease specific treatment, like in patients with cardiac amyloidosis, if patient has AL type of cardiac amyloidosis, then we should give chemotherapy. We should consider this patient for stem cell transplantation and monoclonal antibodies which are targeted against the plasma cell dyscrasias, those can be given. If we give beta blockers, SE inhibitors and ARBs, if patient can tolerate, then it is okay, but usually they are poorly tolerated. We shouldn't give CCBs to these patients. It leads to the worsening of the heart failure. And if the patient has associated high grade AV block, then we should put permanent pacemaker in those cases, and preferably we should put biventricular pacemakers. And so if the patient has familial amyloidosis, ADTR type of amyloidosis, then we can consider for liver or heart liver transplantation together, and tafamidis, which is a TTR stabilizer. And if the patient has wild type of this cardiac amyloidosis, senile systemic amyloidosis, then tafamidis and general treatment principles should be followed. In patients with cardiac sarcoidosis, we should give them prednisolone 1 milligram per kilogram, and that should be tapered over several months. And if the patient has high grade AV block, then patient may require ICD implantation. And heart transplantation should be considered in patients who are refractory to this treatment. If the patient has Fabry's disease, then enzyme replacement should reverse the phenotype, then we should think about enzyme replacement. In cases of hemochromatosis, ion chelation therapies and frequent phlebotomy should be done. If the patient has carcinoid heart disease, then hepatic mets, debulking, use of octreotide, which leads to the tumor shrinkage, and advanced, if patient has developed advanced valve disease, then we should think about the surgical correction of those abnormalities. And patients with hypereosinophilic syndrome, if the patient comes in early stage, then we can give steroids to those cases, and if the patient presents in late stage with distorted valves, then those should be corrected surgically. Thank you.